Minister, good afternoon. You're very welcome here today. And I'd like to say on behalf of the Commission how pleased we are that you've agreed to give evidence both at the beginning and at the end of the public hearing sessions. Today we'll commence with a statement from yourself of up to 10 minutes. We have a pretty tight timetable, so I will be ruthless on timing, and then we will have a number of questions for you. At the outset, if there is anything you want to elaborate on in writing during the phase of the public hearings, we would be happy to receive that from you as well. So,
okay.
So the floor is yours.
Thank you very much, and for the members of the inquiry panel for giving me the opportunity to give evidence at the opening of the inquiry. The discussion paper that you have produced states that the Human Rights Commission are holding an inquiry to examine how the system of emergency healthcare in Northern Ireland respects, protects and fulfils human rights, with a particular focus on the right to health. In response, I would say that everyone in Northern Ireland has the right to have access to health services free at the point of delivery. The NHS was created out of the ideal that good health care should be available to all regardless of wealth, and when it was launched on the 5th of July 1948, it was based on three core principles: that it meets the needs of everyone, that it be free at the point of delivery, that it be based on clinical need and not ability to pay. And these principles have guided the development of the NHS over more than 60 years and remain at its core, reinforced by governments down the years right to the present day Northern Ireland Executive. I believe that the National Health Service remains the jewels in the crown of this United Kingdom. There should be no doubt about the public's right to access these services, and my department's commitment to provide the best treatment available in the right place at the right time with the available resources. However, we need sufficient resources to sustain these services, and this inquiry may be well aware of the challenges that I and indeed my executive colleagues face in the current climate, where we're working hard to address these issues. Emergency care is a service which we all rely on, often in times of our greatest vulnerability and need, and it's vitally important that we have robust services in place to deliver safe and effective care in a treatment environment designed to address a person's need and that affords them proper dignity that they deserve. This relies on many things. Most importantly, we need a skilled and motivated workforce. We need an effective treatment environment with the right equipment, and we need to have efficient and effective systems and processes underpinning all of these. As Minister for Health, I am committed to ensuring that as far as I am able, all of these necessary components for world-class care, emergency care, are in place for the people of Northern Ireland. And what makes my job possible is the tireless commitment of the staff and health service. Let me be very clear. The vast majority of doctors and nurses, porters, healthcare assistants, allied health professionals, and indeed all those involved in healthcare give 100% every day of the week. They give freely of their time to go the extra mile for their patients, and I am sure that this inquiry will join with me in expressing our thanks and appreciation to all of these exceptional people. Mr. Chairman, as this inquiry progresses, I'm sure that the issues of healthcare targets, performance statistics, service configurations, strategies, policies and action plans will be discussed, but we must never lose sight of the fact that at the core we are dealing with individual patients, our families, our friends and neighbours, and that's why I am encouraged that the terms of reference for this inquiry put patient and public involvement so strongly at its centre. With regard to performance, it is important that the inquiry notes that while attendances at emergency departments and minor injuries units have broadly remained at the same level for the past 5 years, around 720,000 annually, the number of admissions to hospital from A&E is rising, putting pressure on EDs and the wider hospital system. In 2013-14, there were 138,499 admissions to hospital via emergency departments. That is an increase of 3.3% on the year 2012-13. And within this context, the elimination of lengthy delays is critical to ensuring high quality care and to improving patient experience. I believe that this can be done. The HSC achieved a 44% reduction in the number of 12-hour waiting time breaches during last year. That is a considerable achievement, and I pay tribute to all staff in the HSC who worked hard to deliver this improvement, but there is still much more to do. While we've seen improvement in the delivery of this service, Mr Chairman, through the course of the inquiry, you will no doubt hear many difficult, indeed sometimes heartbreaking, personal stories from individuals who have had a poor experience of the HSC and who have been let down by our health service. It is important in these circumstances that health and social care openly admit when mistakes have been made, that we discuss these issues frankly with the patients and their carers, and that we always retain a fundamental desire to learn and improve from these patient experiences. But Mr Chairman, I hope that the inquiry will also have a chance to hear from individuals, the very great majority of whom have received exceptional kindness, support and healing from our doctors and nurses. We know that our doctors, nurses and other staff put their patients first and go to work every day with the desire to deliver exceptional care. It's my job as Minister to ensure that they're supported in all necessary ways to do that. Mr Chairman, the Chief Medical Officer is giving evidence later, and he will no doubt provide the proper context for the work that is ongoing to drive improvements in the safety and quality of services across the HSC. Chief Nursing Officer will be able to discuss the key work in improving patients and client experience across the HSC. And I hope that together these will provide the inquiry with a sound basis on which to proceed with its consideration of evidence. For my part, I wanted to take the opportunity today to provide the inquiry with an insight into some of the key decisions that I have taken over the last number of years in relation to the future of emergency services, as well as health services more generally in the province, to ensure that the care we provide to patients remains safe and effective and clinicians feel supported in caring for patients. Throughout all of the challenges that have faced the HSC in my tenure as Minister, I have been clear that my number one concern is and must remain patient safety. I've made it clear that in my statements to the Assembly and public to the media that I as a Minister have a fundamental duty to ensure that services provided to the people of Northern Ireland are safe. I do, however, continue to call on the Health and Social Care Board to work with the Trust in developing plans to ensure that, in as far as possible, 24-hour emergency care services are provided over as many of the sites as is safe and feasible to do so. The HSC has been working hard over this period to ensure that our foremost duty of protecting patient safety is upheld, whilst also maximising, as far as is safe and possible, the quantum of services that are available locally. Mr Chairman, I'm sure this inquiry will come to see that many of the challenges faced by emergency care are not exclusive to Northern Ireland. The most recent challenge was in the Belfast Trust at the Emergency Department of the Royal Victoria Hospital, and there has been significant public scrutiny of that trust, and rightly so, since the declaration of the major incident on 8th of January. After being made aware of the major incident, and in response to feedback from patients and frontline staff, I instructed RQIA to undertake an inspection of the ED and AMU at the RVH over the weekend of the 31st of January. I also instructed RQIA to conduct a more detailed and wide-ranging assessment of the provision of emergency and unscheduled care regionally. And I received these reports in the spring and summer of this year, respectively. The RQIA inspection report made for particularly difficult reading, and in my statement to the Assembly in April of this year, I was clear that I was angry and extremely disappointed at the findings of the RQIA inspection, and let me reiterate that once again. I will not accept a service where old and frail people are not being given proper food or water, not being assisted with general personal care. I was heartbroken at findings which indicate people not being afforded dignity when they pass away in our hospitals, and I made it very clear at the time that I would not accept this, and I have since instructed the Department to oversee a quality improvement plan for the unscheduled services, including the ED at the RVH. This has shown progress. However, in many ways, these instances of terrible patient stories are merely symptomatic of wider-ranging and more complex problems, and that is why I welcome so strongly the findings of the RQIA systematic review in June of this year. You will be aware, Chairman, that in July of this year I made a statement to the Assembly, which accepted all of the findings of the RQIA review and announced the formation of a regional task group led by my Chief Medical and Chief Nursing Officers, with the explicit target of eliminating avoidable 12-hour breaches by this winter and to substantially improve the 4-hour performance over the next 18 months. This work will be vitally important. The amount of time that patients wait in the emergency ward is a measure of the quality of our services and of the importance that we ascribe to it, and we cannot ignore it. But time-based targets are not the only or even the best measure of performance. Most important measure is that patients receive the safest and most effective care possible. And that is one of the reasons I set out the elimination of avoidable breaches. Let me be clear that if there are circumstances where a patient must wait to ensure that they receive the safest treatment, then that is what I expect to happen. However, let me be equally clear that that should be the exception. Mr. Chairman, the issues which have arisen in our EDs during my tenure as Minister have convinced me of the need for a fundamental set of values and principles to guide emergency and unscheduled care in Northern Ireland. These principles and values must be a benchmark by which I as a Minister and the wider public measure performance in the HSE. That is why I asked the CMO and CNO to make this one of their first priorities in the regional task group. You will appreciate that the work of the task group has only just begun, and I'll need to take the opportunity to consult with both the public and my colleagues in the Assembly in finalising these. However, I can tell you that these values and principles will go beyond waiting times and targets. We want to see services that are timely, evidence-based, sensitive to individuals' needs, and which meet the patient experience standards. I want models of health and social care delivery to be founded in collaboration and partnership, working across all trusts and HSE bodies. I want every aspect of the system to work together to better meet the needs of the population, and I want the HSE organisations to continue to be learning organisations, to share innovations and quality improvements across the system. And I am determined that these values and principles will strengthen the basis of how my department holds the HSE to account for its delivery of unscheduled care. These values will build on the work of Quality 2020 and the patient experience standards that Michael and Charlotte will talk to you about later. In a statement to the Assembly on the 8th of April this year, I set out my strategic approach to securing improvements in the delivery of unscheduled care across the HSE. In conclusion, Mr. Chairman, there are three key elements: a review of unscheduled care conducted by RKIA, which has now been reported and its recommendations are being implemented. Secondly, staff involvement, which will be driven by unscheduled care task group. And thirdly, securing a step change in the quality of governance arrangements across the HSE, which is the subject of a study being carried out by the former Chief Medical Officer for the Department of Health in England, Professor Sir Liam Donaldson, to be completed by the end of the year. As I said in the Assembly, I'm confident that the strategic building blocks that I have put in place will in time deliver a step change improvement in the quality of care provided to patients and the quality of governance arrangements across the health and social care in Northern Ireland.
Thank you, Minister. I'll start by asking some questions, and then I'll pass you to my colleagues. I wonder if you could, first of all, just outline to us to what extent you think the recent difficulties in accident and emergency, which have been very much in the public domain within the Belfast Trust, have actually been an issue of resources, and how much you think they're due to other non-resource issues, for example, management and culture, governance, and other issues, and then just how you intend to tackle each of the resource and the non-resource questions.
My view is that it is a resource plus organisational issue, and the resource issue may not be a resource issue in emergency departments, but may be a resource issue in other elements of the health and social care. We in Northern Ireland are privileged to have integrated health and social care, and therefore should be at an advantageous position when the social care element is called upon to assist the healthcare sector. And the issues that I believe manifest themselves on a regular basis in our emergency departments is that they do not have the ability to have people move on to other parts of the hospital in as timely a fashion as they should, because beds are not available. I suppose some people would suggest that you should make more beds available. Others will make the suggestion that you should ensure that people do not spend as long in hospital. If it's not the appropriate place for them to be, then they should be moved to somewhere else which is more appropriate, whether that be the home, whether that be another facility, and that is where social care kicks in. That element of it, I believe, is fundamental to resolving the problem in our emergency departments. If we get the social care element of it right, and ensure that people are discharged in a timely fashion from hospital, the availability of beds throughout the hospital system will be much greater. The inevitable consequence of that is that if there's a greater availability of beds, then the flow from the emergency department to other elements of the hospital will will be much more responsive, and that is something which I think we would all welcome. So that aspect of it, I believe, is organisational, and that we need to ensure that element of organisation at the other end of the hospital, the discharge end of the hospital, will allow for a freer flow of patients. I think that we probably have systematic issues around people who require x-rays, scans and so forth. And whenever doctors book patients in for such activity, and the waiting time appears to be somewhat longer than the public want, many people will actually turn up at emergency departments looking at those kind of services. And will actually get it by coming through the emergency department system. And we really need to ensure that in terms of radiology, that we are much more responsive to what the public needs. So when primary care says we need the use of radiology, that should happen much more quickly than is the case. So there is probably an issue around resource of radiology and ensuring that people do get those scans more quickly and consequently don't end up in emergency departments. I suppose underlying all of this, we are living in an era where there is considerable change. We have a much older population than was ever the case before. Many of the people who turn up to our hospitals are elderly. They have many complex conditions all at one time, and that can cause issues in terms of being admitted to hospital because hospitals have been down the route of specialisms, and that's happened throughout the United Kingdom. We do not have the availability of generalists to the same extent. The generalists largely exist in ED. That has caused issues and problems for us in that you have someone arrives at the hospital, they have comorbidities, and consequently someone is saying, well, that's not my area of expertise, that individual shouldn't be coming to my ward. And the same happens, and there can be a bit of discussion and passing things from one to the other. The patient just needs to be admitted and treated, and it needs to be a closer working together. And that's an area that we certainly need to look at. And again, a lot of it relates to organisation. So resource is an issue, but better organisation can certainly address considerable amounts of the problems that we face. So it's not purely about getting more money for health in that respect.
Okay, thank you. I don't think you find anybody who would disagree with the importance of the integration of health and social care stretching through A&E and beyond. I wonder if I can ask you, though, in terms of, and you placed the importance of the care of patients, which was central to your statement. I'll ask you a little bit about waiting times. One of the findings of the RQIA report was that at times on the ground, the need to meet the target appeared to be driving care rather than the care issues themselves, the kind of so-called get someone admitted within 11 hours and 59 minutes, to characterise it in that way. I wonder if you'd say something about how you view that kind of issue and how you would address it, but also if you'd say something about how else the department monitors the patient experience beyond the 4 and the 12-hour target. What are the other things that you look at when you decide whether things are improving or otherwise?
Well, targets, I think, whilst they are useful, they in and of themselves are not the only means of measuring performance in ED. In fact, they're not the most important means of measurement. Certainly for media and so forth, it's very easy to pick up you failed to meet a 12-hour target, you failed to meet a 4-hour target, and so forth. I think it's much more important that we look at the quality of care that's provided and have measurements on that front. However, at the same time, the 12 and 4-hour targets were introduced in 2007. I believe that they are important, and I don't think that they're unreasonable thresholds. People waiting for 12 hours is a considerable period of time, and people should be admitted to hospital by that time if they're going to be admitted, or should be discharged by that time. I don't think that is reasonable that people are waiting beyond that time, and have made that very clear repeatedly, and have indicated that I want those waiting times eliminated, and for there to be exceptional reasons whenever they're exceeded. And there may be exceptional reasons. You know, you could have someone who is actually required to provide treatment and advice or engage in surgery and not be available for another several hours. These things can happen from time to time, but they should be exceptional as opposed to the norm. In terms of the other indicators, there's a percentage of patients in type 1 and type 2 of EDs are triaged at each level of the Manchester triage scale. We look at the length of time patients wait in emergency care broken down by 2-hour time band, patient and ambulance turnaround times, the percentage of unplanned reattendances of patients to an emergency care department within 7 days of their original attendance, the total length of time patients spend in emergency care departments, the number of patients who leave before their treatment has been completed, time from arrival to triage and from triage to treatment, and the number of GP referrals to emergency departments. And these new indicators, when taken as a whole, aim to balance the more simple 4 and 12-hour timeliness targets with a comprehensive view of the quality of care, which will include outcomes, clinical effectiveness, and safety, which, in my view, are all much more important. They help to measure performance against some of the key concerns which patients have when they have to go to an ED, such as the anxiety or discomfort caused by long waits, or their desire to be assessed quickly to determine their clinical priority.
Yes, and supplementarily, when you look at those targets in the round, do you have a sense that the service is improving or deteriorating overall? When you clearly the 12-hour waiting time target has improved quite significantly, but looking across the piece, what's your sense of the overall service?
The 12-hour has improved dramatically. The 4-hour has slipped, so I'm not satisfied. I want to see improvement in the 4-hour, I don't want to see slippage of it. So I think that there's a lot more that can be done. I also think that in terms of the people who come to the emergency departments, we have a considerable amount of work to do to get that right. We have too many people turning up to emergency departments who shouldn't be at ED and should have been dealt with through primary care, and we can do more on that, and I think that's important. We have people who are turning up to emergency departments whenever they should be going to minor injuries units, and again, I think that we can do more to publicise the availability of minor injuries units and have people directed that way. I know many minor injuries units work extremely well. People are in and out of them in 30 minutes and an hour and get all of their needs met in a perfectly appropriate manner. So those people who are using those are having good experience. I don't think enough of the public are aware of the availability and the extent of the service that can be provided. So there's certainly work can be done on that front. And the one that I find most important is our elderly population, because I don't think that emergency departments in general, I don't think it relates exclusively to Northern Ireland, it's anywhere. Emergency departments are not that appropriate location to admit elderly people who have a chronic illness and need to come into hospital. So when a general practitioner identifies that this elderly person has a chest infection or indeed believes they have a kidney infection, there needs to be a much better direct admittance procedure taking place. And that is certainly something that I know that we're looking at and giving consideration to even for this winter in some of our facilities, because I think that we can have a much more dignified pathway for our elderly people than is currently the case. Emergency department by its nature attracts everyone. Very often you have people who are well inebriated, people who are aggressive, people who are violent, even very young people involved in our emergency departments. And when you get all of that mixture, it's very, very difficult for the staff to ensure that people always have dignity, because some people are behaving in a very undignified and unedifying way, and that compromises the level of dignity that you can afford to others because of that misbehaviour. And that's the circumstances that people have to work in and have to make the best of. So you could understand why if I could identify pathways which would remove vulnerable people such as our elderly and people who have regular chronic illnesses that they have a more direct pathway to being admitted to hospital or for treatment, then that's something that I wish to pursue.
Okay, Minister, thank you. I'm going to pass you to my colleague Paul, and then Marion will complete the questions.
Many thanks, Minister. Thank you very much for making the time to share your insights this afternoon. And I'm struck by the passion that shines through some of your remarks, and I find this really refreshing. I wondered if I could ask a couple of questions about monitoring and accountability. One of the questions that we signalled earlier is question 9, asks whether or not your department adopts a human rights-based approach to health. And I noticed in your remarks, I'll study them carefully later, but I noticed in your remarks you talked about principles and values rather than rights. Before I invite you to comment on that question about whether or not your department adopts a human rights-based approach to health, I wondered if I could just note a couple of things, if I may, as briefly as I can. There are now a number of governments that are using a human rights-based approach to health to strengthen their health policies and their health practices. The one example nearest to hand is in Scotland, actually. In about 2000, there was one particular health institution in Scotland that was causing a lot of concern, and it was subject to a critical report. And the health authorities decided something had to be done, and they decided to place human rights at the centre of the process of change. And they were talking about human rights of everyone involved, not just human rights actually of patients, carers and family members, but also the human rights of staff. That, as briefly as I can, Minister, that process of change, looking at human rights and reform, that took some time. Policies and practices were revisited. Some remained unchanged, but some were revised in the light of this exercise. Because, of course, human rights aren't just about going to court. I mean, human rights taken into account can shape a policy that keeps a government out of court. So my point is that a few years later, there was an independent evaluation of this institution, and it was found that there were gains all round. The staff reported they were less stressed, they were less anxious. Patients reported significant improvements in their care and treatment. And time doesn't permit, I'm not going to bang on about it, but Scotland's not the only example. There was a WHO study published last year which demonstrated a human rights-based approach to health contributed to health gains for women and children. So please excuse me for taking up your valuable time, Minister, but turning to that question, I wonder if your department has yet explicitly adopted a human rights-based approach in any of, I know not in all of, but in any of its interventions. And if it hasn't yet, is this something you are willing to give serious attention, serious consideration to? And conscious of the time, one other short question, if I may, Minister. I was very interested to learn about Sir Liam Donaldson's brief that you referred to in your remarks, and I'd read about earlier, advising you on improvements of governance arrangements. It seems to me that this is extremely important. I mean, I was much impressed by Compton report, but I was also struck that it was, you'll correct me if I'm wrong, but it was silent on governance. I think a powerful report, but silent on governance. So I understand the importance of Sir Liam's work. And my question is about Sir Liam Donaldson's work is, what are your main governance concerns? Thank you, sir.
Okay, thank you. In terms of the whole series of articles and pieces of legislation that we're applying, and I'm not sure whether it would be as beneficial if I read it all out, as opposed to give you what my thoughts are on it. I think at the outset, everybody that works in the works within health and social care need to recognise and need to realise that this isn't a factory, it isn't a production line, it isn't something which is purely on targets. There will be targets. This is about human beings who have come to us because that human being actually has a need. And sometimes the need may not be as obvious because it may be a mental health need, but that individual may manifest that in suggesting that there is something else wrong with them, which is actually the problem. There may be another problem with their health, but maybe mental health, and that also needs to be addressed and treated with dignity, and the importance of that need identified. But I think at the outset, everybody who works within health and social care need to have it instilled within them, and they do have it instilled within them, that this is human beings that you're working with. And no matter how it was whenever you left home this morning, no matter how difficult the circumstances whenever you left home this morning, you are coming in here to provide care for people who need it, and therefore you must provide the best possible care and work to the best of your abilities. No matter of the pressures that you face, you may seek to ensure that, or you must seek to ensure that you provide the level of care that you would want afforded to your loved ones. Now, is that always the case? It certainly isn't, and that's disappointing. Thankfully, it is the case, the vast majority of times. And the feedback that I get on health and social care, whilst in the media, it can be very negative because the media, do bad news stories. They don't really do good news stories that much, and that's the nature of it. And it's not a criticism; it's just a statement of fact. If 100 planes land successfully, that's not a news story. If one has a difficulty, it is, and that's just the way things are. But the population per se, I know from the feedback I get from mail, and from the feedback that I get from meeting individuals from social media and so forth, the population in general are impressed with the care and dignity that is afforded to them in our health system. And I think that, you've suggested that a facility in Scotland has seen massive improvement as a result of introducing a human rights agenda. And we're certainly happy to look at that and to look at the positive experience and look at perhaps other aspects that played into that improvement. In all of these things, our desire is to deliver a better health service, an improved health service. In a changing environment where demands continue to increase and where we are continuing to keep people living for longer, and therefore we have greater complexities which demand more people's times. In terms of governance is critically important to all of this, and good governance and good standards of governance are of critical importance. I think that at the same time, we do spend a lot of time monitoring activities, and I'm not always sure that is best use of resource. I think at a personal level that too much of our staff's time is spent on writing up various reports, on going through various things that they have to do, as opposed to spending time with patients. And we live in what is a litigious society as things stand. We are facing greater levels of claims for clinical negligence. Indeed, for smaller things, people are now claiming for clinical negligence. And the consequence of that is that people do have to cover themselves, and leads to more time being spent at the computer and less time being spent with the patients. I'm not sure whether we can overcome that, but it's certainly an area, excuse me, that I think is negative, that we have our nurses spending considerable amounts of time having to do that, as opposed to spending that time with the patient. I think the time much better spent.
Well, thank you, Minister. I welcome the willingness to at least give some consideration to a human rights-based approach to health, which, in my humble experience, can reinforce some good stuff that is often going on in the health system, and it can help make some refinements. time is short, so I won't ask any supplementaries.
Okay. Marion, would you finish the final questions for today?
Minister, I have 3 questions really around the issue of participation and the use made of feedback. The first one is really stating, what you've already recognised, that emergency departments regularly deal with patients with mental health needs or elderly people with varying levels of trauma or children. And I'm wondering, how are the particular needs of such patients identified and met in an emergency department, and what processes are in place for listening to groups representing patients with such particular needs?
Well, one of the areas that we're currently doing and investing time in is the 10,000 Voices scheme, and that enables the public to participate in a way which we are assessing all of that feedback and is providing valuable feedback at this point of patient experiences. And patients will very often relay their positive experiences, but we're also picking up patients who have less positive experiences. And we want to hear the bad. It's important that we hear whenever things aren't working well, because it enables us to address that and seek to ensure that that doesn't happen again or be repeated. So that is an area that we think that we can achieve something significant on. Obviously there's normal complaint systems, but the 10,000 Voices is something which is relatively new and is currently being carried out across our health and social care sector.
And would you envisage the findings from the Donaldson review influencing the department of public participation?
I will await and see. Donaldson's focus is on safety, and that is our number 1 priority, as I indicated at the outset. I would much rather be treated safely in 6 hours than be treated unsafely in 2 hours. But Donaldson's work is focused very much on safety. He has the expertise and the knowledge, and we will be given a huge amount of cognizance to the recommendations that will arrive from the work that Sir Liam Donaldson and his team will actually carry out.
And finally, some staff have reported that there's a culture of bullying in relation to meeting the waiting time target. Is the department aware of these allegations, and if so, what action is the department taking to remedy the situation?
Well, certainly there is certainly we have picked up that might be the case in some instances. It isn't something that we have a massive empirical evidence on, but nonetheless individuals feel that they're being bullied, and consequently we need to ensure that they're dealt with appropriately. I think that everybody is under huge pressure. The public have an expectation of healthcare, and the public expectation would come to my door, come through assembly members, come through the media and the public complaint system. And I'll be honest, I apply pressure on Michael and Charlotte, on the trusts, to respond to these things. The managers in the trusts are applying pressure to people who are working for them, the sub-managers who are applying pressure to people who are actually working on the wards. And it is important that as we apply that pressure in response to the public demand, that we do it in a way which is collective. We have a responsibility here to meet these needs, and we need to ensure that we provide the appropriate care, and that it isn't done in a bullying way. And I suppose all of us by nature are different, and some people are better at handling other people better. Some people will have a more domineering attitude, which may come across as bullying and may be bullying to another person. So a lot of that can be to the individual. What I may perceive to be bullying activity may be something which is different from yourself, and that's the nature of life. But in all of this, we need to give consideration to our staff's well-being, our staff's mental health, and we need to ensure that our staff are well motivated. We also need to be conscious of the fact that staff are bullied by the public, and there's people coming into emergency departments. Some of them will have alcohol, some of them will have drugs, and some of them will just be naturally aggressive. And I would want to say, and have suggested to my colleague in the Department of Justice, that there should be a fining system for individuals who behave as spot fine, for individuals who behave in an unacceptable way in our emergency departments. My view is if you can fine someone £90 for parking 3 inches over a line on a road, someone who's coming in and using foul language, threatening people and being abusive and aggressive, it would be an immediate check for their behaviour. I think a lot of these people should be prosecuted. We have instances where ambulance drivers, where you may have two individuals out in an isolated place and people lash out and attack them. These are totally unacceptable circumstances. So whether the bullying's coming from within the system or indeed users of the system, I think that there should be a zero tolerance of bullying, and we need to ensure that that's the case, and we'll be listening carefully to any evidence that is produced and taking advice that is provided on that issue.
Minister, thank you. That completes our questions. I'd just like to finish by thanking both you and your officials for the engagement and the commitment to come again and speak to us at the end of the process, where we will be much better informed of what providers and family members and others' experience is from having gathered the evidence publicly. And it's very welcome that you've agreed that level of engagement. And to wish you good luck with your endeavours with the health service over the next few weeks and months.
Thank you very much
Very much indeed.